easiest way to get into the
This is Josh Dibble from integratingpresence.com. And as some of you know, Denny K Miu and I do a monthly Ask Us Anything. This coming month, we're having on a guest who's talking about redefining caregiving. And so I thought I'd sit down virtually with Ron here, which is not his real name. Ron, why don't you mention, a brief bio in where this all fits in, how it's related?
Sure. Yeah. When it comes to questions of redefining health and healthcare and how people operate in that space, of course, a lot of the attention is focused on insurance, government roles, the impact of major hospitals, your private physician, things of that nature. And there's a lot of opinions around that. There's a lot of politics around that. And I think everybody has their own vantage point. So maybe what we can talk about is a little bit of the vantage point that I could provide as someone who has worked in hospital systems and for a major player across multiple states, nearly $8 to $10 billion in annual revenue. So a pretty large healthcare system where I had the opportunity to work as a frontline person on the revenue cycle side within an emergency department, within a hospital direct admission department. Also had the opportunity to supervise and manage teams within that direct hospital climate, as well as several roles in quality and project management within the revenue cycle organization of what we might call a back office type of concerns. And that's where we're getting into contracts, authorizations, insurance company behavior, client behavior, things of that nature. So just some of the things that we've seen, some of the things that might be questions in regard to, how does this work? How could it be better? What are some of the obvious flaws that you see, both not necessarily from a medical standpoint, because I'm not clinical, but from a bird's eye view of seeing how the clinical side works. And then as well as that, how the insurance and people's approach to things impacts their care. And then we can connect that to really what is the broader agenda and purpose of having a healthcare system? What should it look like? And are we on the right path to that?
This is a perfect setup. Yes, all those things are of great interest, especially in the hour we're in as well. So please dive right in.
Yeah, so I think the first thing is when we talk about healthcare and we talk about health, so much of what we experience in an actual clinical setting, especially if you're getting into this is an emergency or this is urgent, or sadly, even if you are setting up an appointment with your primary, is focused on the old pay for service model. So while there have been movements and the government through CMS claims that they're really looking for quality and outcomes, one of the things that's a bedrock is if you go in to see your physician, you're going to be asked for your top issue of today. What is it that we're dealing with today? And that's going to be, if you're lucky, a 7-minute visit with your physician. Now, you might be there for 45 minutes. You might wait for 15 before you get back. You might wait for 10 while you're in the room. But at best, you're talking about 7 minutes with a physician. And half of that, they're going to spend typing notes into the computer. So not a lot of focus holistically there. If you have any kind of an urgent need, again, it's going to be one primary item. And we know from a health standpoint that there are multiple factors that integrate. And if you are operating by piecemeal, you're really not going to get the kind of advice or get the kind of treatment that's going to enable you to connect the dots together. It would take certainly more than 7 minutes to take any kind of a chronic condition and talk through the diet and exercise requirements as well as limitations. But the system itself is more or less set up to drive you to how can we look at one item today, and then how can we medicate that by giving you a prescription so that these numbers start to look better. And that seems to be one of the problems, because if you're truly interested in establishing full health, how are you going to get there when we're slicing portions of that out and just saying, well, what is your particular issue today? Are you struggling with your diabetes? Was your cholesterol too high? Did you sprain an ankle? Some of these things are acute and can be handled simply. But others are actually, more complex. They're more interwoven, but that doesn't blend well into being able to drop a claim and bill it out to an insurance company. So we do have an issue there where the focus on wholeness and well-being isn't really a primary thing that's built into the system. Instead, getting you in and out as quickly as possible so that we can code that and drop a claim and bill insurance is really still the goal, regardless of the lip service paid to quality of outcomes.
Wow. So we've got basically it's structured for a one item thing from the client or the
Patients.
7 minutes and a prescription, basically. From what I gather, this has been structured just for the convenience of insurance companies. Is that too inaccurate to put? Or if it is, when did this type of structure, system structure come about? Because, you look back on old shows or you talk to grandparents and stuff, and they have more of a doctors and healthcare providers didn't seem to operate this way for the most part. I don't know when the time period would be.
Yeah, and that's it. When we look at the trend line, there are things that we should highlight with the introduction of the Medicare and Medicaid services. One of the things that I think most folks aren't necessarily aware of, they see it in their end bill, but they don't know the origins, is going back to the way that those claims were paid. So prior to some of the legislation in late 60s, early 70s time period, when we're talking about reimbursement rates, those old school doctors that were running, local clinics would be billing for the actual services rendered. And this is very similar to what you see if you go to a veterinarian. It's pretty similar to what you see if you go to a dentist's office, where you don't have the same penetration of insurance companies and you don't have the involvement of the federal government into that sphere to the same extent. So what happens if you go to the optometrist, whether you have insurance or not, is you end up paying a fee that's relatively similar to what that optometrist actually wants to charge you. So if it's going to be $50 for an eye exam and that's what they're looking for, basically they charge $50. Within medical insurance, one of the biggest problems that we have is the contractual rates that are set by the federal government are set by the federal government itself. So instead of paying the full charges, what they'll do is they'll pay their percentage, and they set and cap those rates themselves. So you end up with percentages that can vary state by state if you're looking at a Medicaid program, and they can vary service line by service line for Medicare. But the bottom line is this: the bill will be for $1 and they'll say, we're going to pay 30 cents on that. So what ends up happening predictably is if you actually needed $1 and you're only getting paid 30 cents, you're going to raise those prices, 3 to 4 times the rate. Of course, the other thing that happens when you're not being paid the full amount is you have to start compensating for that. So if I have 4 patients in an hour and only one of the 4 are going to pay, then I'm lagging behind in terms of the revenue I need to make. I have 3 slots to fill in terms of actual patient payments in order to keep the lights on and pay my staff. So what I have to do then is I have to start becoming more efficient. At the same time that's happening, we know there's a general push in society, and the organization I was working for very clearly had a push toward profitability over people. It was much more of an organization run from a business standpoint, a maximization of efficiencies and profit opportunities as compared to taking care of patients at the start. So you have difficulties in terms of your reimbursement. You have these capitated rates where the actual bill is for $10,000, but federal legislation says, well, we're only going to cover to $1,500, and all of that is a write-off. If you do not have insurance, of course, you're not looking at any of those contractual rates. You don't have any of the benefits from those government determinations. Instead, you just get those really high bills. And that's part of the situation you see with individuals getting these $40,000, $60,000, $80,000 bills. Well, if you have Blue Cross Blue Shield and they have a contract, they're not paying that percentage. If you have Medicare, they're not paying that percentage. And that's part of where the numbers get so high and why you don't see the same type of behavior in a dental environment. Say you need a root canal, it's expensive. but you're not going to walk out of there owing 20,000 because the 3 to 4 that it may cost, or if you're lucky, less, is actually the amount that they're trying to recoup. Yeah, I don't think I'm really disillusioned about the environment as a whole. I think for me, it was just a particular thing for the organization I was working for, that I didn't like the way that they were conducting business. That system, that healthcare system, had changes in the top leadership position within my time period. We had a complete flip in terms of the C-suite, and the mentality that went along with that had changed. So when I was first joining with the organization, there was a different mentality and more of a patient-oriented concern. And then that changed and refocused on the profitability and things of that nature. So personally, I still think there's a lot of value and a lot of good available in those systems, but the board has to appoint people and select people who are actually going to put patients first. So I still think it's a good industry. I think that it can be vulnerable to individuals running it for their own headlines or their own personal well-being, as opposed to the organizations.
That seems pretty common with folks in your situation, that, yeah, the leadership comes and goes, and some are more conducive to, goodness, well-being, and actual care and health than other leadership teams. Like you were mentioning before, that seems to be a pretty common criticism across the board. What are some kind of fixes or solutions, or maybe some right questions we need to be asking, to, short of scrapping the whole thing, which I don't think is going to happen anytime soon or even be possible? I mean, if so, there would have to be some kind of bridge or transition. So if that's something you would happen to be for, then yeah, what would be kind of a transition? What kind of solutions seem more obvious? And then maybe which ones don't seem as obvious, and then short term through long term?
I think there are two things that jump to mind to me. One is an item of personal responsibility and possibility, and that's in the domain of diet and food availability. Just when we look at the impact that diet has on overall health outcomes and well-being for individuals, we know that the links are there. We know that the proper decisions in terms of diet and what to eat, what not to eat, what kind of items we should be consuming has a tremendous end impact. But we also know that there's pretty heavy involvement of the government in subsidizing the types of things that we shouldn't be eating. So, if you make your murder zero list of all the things that are going to cause you harm, you're going to have things that are ultimately all in some way subsidized, from your corn to your cheese, your high fructose corn syrup, cattle ranches, all of the things that essentially taste really good, and they create this just incredible plate for you when you're hungry, but the actual contents of it are not very good. So we should be asking some questions about why our government props up so much of a diet and so much of an agricultural system that is not beneficial for us personally as consumers. I think, as our representatives, the government really should be looking for, how can we provide a healthier population? How can we push things in a better direction? Within that, you have questions of food availability and equality. We know when we get into socioeconomic status, the lower you are in that SES ranking, the higher the probability is that you're going to have a wider range of chronic diseases, and the less likelihood that you're going to have good access to high quality food and nutrients. So it's not a mistake that you see high rates of type 2 diabetes and metabolic syndrome in poverty-stricken areas. It's a result of, yes, exercise, but just as much the quality of the food that's available in the local environment.
So Ron, let's say I'm your GP, your general practitioner, and start talking about food. Won't I just refer you to a nutritionist?
I think from what I've seen, that's a pretty limited sphere of opportunity. Going back to the general structure of sort of rushing people through, most of the food problems that we have a correlated generic drug that's going to work for that. So you've got your cholesterol, you've got your blood pressure drugs, you've got your metformin for your diabetes. That's particularly more common. What you will typically see with a nutritionist is somebody who's new to a particular disease. A lot of times you're going to see that more limited to someone with like an onset of type 1 diabetes, where you have to now regulate this blood sugar and diet. Some of the autoimmune diseases, you'll have that opportunity. Sometimes if you're having dermatology issues, then you can do some of the food sampling, but it's not a particularly common thing for people to actually delve into, other than just to say your diet should be better. But in terms of nutritionists, I think that's a great direction to go in, and to have those individuals available, particularly because the food itself is so complicated. It's easy to say eat a certain way, but we find very quickly, because foods aren't made of just one ingredient, that when you increase the amount of carbs, and to decrease the amount of fat, then you got a problem with that. Or if you have to keep low carbs, then suddenly you're looking at foods that are potentially going to have too much fat. Like putting together a balanced diet is a challenge, but it's even more of a challenge when companies and local organizations, local farmers, things like that, are competing against others who have subsidies. And so they're not playing on a level playing field. And then if you bring in some of the difficulties that may come in with having to use certain type of seeds in order to qualify for bank loans, we know that it's not as easy to approach things on a large scale for that quality. So, I mean, that's one of the things I think is a potential where people can have more control. I see
it totally is. And I was, and I don't know if it's changed since I've heard last, that doctors really don't spend much time receiving training and education on food and diet compared to all the other things they train and study with.
Yeah. And that's really the case. And I'll say, in the years that I worked in an emergency room, and I was present for hundreds of evaluations because my role just kind of permitted me to be in the vicinity. And there really weren't conversations happening around food. If somebody comes in for high blood pressure, obviously they're going to say, "Oh, you should watch your sodium." But how to make that practical and how to push that forward holistically, it's not really addressed. I haven't heard it addressed. It's not that there aren't some physicians who are doing it. The problem is it takes a while to work through that. Plus, you have to be kind of educated in that area yourself. And we know there's the joke, of course, about the quality of hospital food and things like that, where it's really not prioritized because it's a reductionist model. We're not trying to solve everything with kale. It's saying, well, we go down to the cellular level. What's out of balance? Let's put it back in balance. And, in all fairness, this is not necessarily the medical profession's fault, or, they can give you advice on how to solve it. But it really is more of a question of politics and economy for citizens to ask our government, why are you subsidizing this business instead of that business, when this isn't leading to healthy outcomes? What about the quality of the drinking water, the air, things like that? I'm not sure if this is true or not. I heard it, but I never bothered to fact check. But I did hear that Russia was focusing on converting their agriculture to food from regular, Western style agriculture to an organic agriculture within the next 5 to 10 years. And it was classified as a national security issue because of the impact it has on the actual citizenry. So I've heard that. I don't know if that is true, or if it's just something that I heard from someone who heard it from somebody, but that's a factor in how where we're at when we go to the doctors. In regard to things that I think help, one of the trends that's emerging from the medical field and seems to be growing is an increased use of nurse practitioners and physician assistants that are overseen by attendings or a primary within a clinical setting, but don't require the same level of schooling and the same investment upfront in order to get to that level. And I think that's a really good trend, because for a lot of individuals, access to care is the primary issue, and being able to go through relatively simple things and have somebody there who can give them decent advice. And for many people struggling with chronic issues from lifestyle choices and from medication elements, they may not have really had the opportunity to sit down and speak with someone about that in depth. The more that we integrate nurse practitioners and physician assistants who are well versed in the basics, but aren't necessarily going to be making diagnoses on extremely complex cases, the more opportunity there is for healthcare to be available for everybody. The model itself does lend to a restricted number of end physicians. We know in any given year, like right now, we've just started another term, at all the medical schools. We know that there's a certain amount of applicants and there's a certain amount that's accepted. Quite a few people would like to be doctors. Quite a few people apply to medical school and don't necessarily make it through and don't qualify as physicians. But that doesn't mean that those individuals weren't capable of providing quite a bit in that domain and in that sphere. But we've set up a lot of somewhat arbitrary rules around how we do our training and what those requirements are in order to actually produce a general physician, someone who is able to just handle the day to day, and that is unfortunate because those restrictions into who can go to medical school and how high you have to score on your tests and the types of residency programs and things you have to do just to become a doctor. Some of that is pretty darn extraordinary when you're not necessarily going to be dealing with super complicated cases day in and day out. A lot of it's going to be the same sort of thing over and over again. When it's flu season, it's flu season. When it's a sinus infection, it's a sinus infection. And when you're diagnosing diseases and you're working within the pharmaceutical model, oftentimes you're just prescribing a broad spectrum antibiotic. And you may have not even been right about what you thought it was, but since it's broad spectrum, it works and you get the good outcome. So I think it's a positive when we start expanding the domain of healthcare practitioners, whether it be nutritionists coming on board and being connected to that in a better way, or broadening the field of who qualifies as a practitioner.
The food thing is very interesting, and I'm going to restrain myself from the GMO organic comments. But yeah, it seems fairly obvious to me. I was just curious, did you have any nutritionists on staff there?
At the hospital, we had one, and that individual worked essentially a per diem type situation. So if you were admitted to the hospital really for onset of type 1 diabetes, then you would set up an appointment with this individual. You'd fill out a 10-page questionnaire on your dietary habits, and then she would have like 1 or 2 counseling sessions with you to talk about monitoring, your carbohydrates and watch out for simple sugars and, monitor the glucose and your A1 numbers, keeping those in good shape and things of that nature. But that was often the extent of it. There are very few conditions other than type 1 diabetes would ever come in to see her. And there was only one person on staff and she wasn't there all the time if she had an appointment book. And so if there were appointments on Tuesday, she'd be there. But it's not as if that was a standard part of it to say, let's do multidimensional rounding. Let's have a team that can really interface with people on all levels, and it's very expensive, but if you were on some kind of gold plan, you're Jeff Bezos or something, and you're going into your own private wing of the hospital, they're going to bring in a full multidisciplinary team, and you're going to have more there than just one physician. It's kind of like they'll load up on physician specialties. So you can have a pulmonologist in there, you can have a cardiologist in there, you can have the hospitalist that has the admission is overseeing your stay, and they'll stack those guys up as much as they need to. But some of the day-to-day things that actually are the building blocks of why someone's sick, you don't have that as much. So you're not going to have a nutritionist on those rounds. You're not going to have a physical therapist or exercise physiologist. Like there's not even really such a thing within the medical sphere. You have to be like on a sports team to have a doctor who's there to also help with your physical stuff. So, those are things that they reflect personal responsibility. But what that ends up happening is the patient comes in, you treat a portion of the illness, control that to some extent, but you haven't addressed anything root cause. So then they're going to keep on coming back. And that works for the medical system because, again, we want to treat one symptom for today. We want to have a visit for 7 minutes that we book for 15 and drop a claim and build that out for, and to be able to have a metric and a traceable outcome, which you don't really have if what you're documenting is a 20-minute conversation about overall health and well-being. Plus, in all fairness, how many patients are actually going to comply with those recommendations anyway? You can have like the Patch Adams Clinic where, we're going to, heal with laughter and we're going to do all these positive things. What percentage of people are actually going to benefit from such an open-ended environment? What percentage would just simply listen and say, yeah, sounds great, and then not go and do it anyway? In many ways, the medical model is around because it works. If I just have to take a pill and that's all I have to do, yeah, I might do that. If I had to change my entire lifestyle, probably not.
Great point. Seems so obvious once it's thrown out there, but it's not on the forefront of many people's minds that have to go visit doctors and whatnot. I thought it was fascinating too to actually kind of find out how the food industry and the subsidies actually kind of intersect with the healthcare system, because trying to find out, suss out the bolts and nuts behind, how that would work. And of course, a lot of this does boil down to the money and how much that affects everything. I was just curious too about how many staff members are on the physician side.
Oh,
because I was just trying to get a reference point for like, if there's only one nutritionist for how many, other physician related employees.
Oh yeah, that's a good point. Yeah, so that particular location had about 450 beds. So it would be one nutritionist for 450 potentially admitted patients, plus the volume coming in through an outpatient environment, which includes an ER. So it's pretty stacked in terms of, you're talking a ratio of 10,000 to 1 in terms of opportunity to actually meet a patient. So that's the physician number. That tends to vary because most of these organizations are working with physician groups that are external vendors. So you'll have a vendor that provides ED physicians, just like any other, like a maid service where, I know I'm going to have 3 maids here to help clean tomorrow. I don't know which 3. So I contract out to make sure that I always have 3 positions available. So that comes up. It's a good question too, because you're talking about ratios and, what number of patients is handled by any particular clinician and how much time does that provide. A physician in an ER environment is usually going to carry 12 to 15 patients at any given time. And that's assuming a normal level of inflow. If we have a really heavy flu season, or if there's an accident nearby, things like that, obviously the number is going to spike. But on a normal day, you're going to be juggling 12 to 15 at a time the entire day. And so what are your limitations there? We're going to run some tests and see. Nurses are typically handling 3 in an ED and up to 10 to 12 on a medical floor for admitted patients. Higher number on the medical floor because they're stable. So if I work in a cardiac unit and I have 8 patients, with all due respect to the individual 8 people involved, they're probably going to be relatively similar. So we're monitoring values, we're rounding and making sure that everything is okay, but we're not dealing with distinct new things that are coming up. So you'll see a higher ratio of patients to individual nurses. But at the end of the day, that ratio controls the staffing. So if we are going to have 1 nurse for every 8 patients on the medical floor, then if we have 16 patients bedded, then we're going to have 2 nurses. If we have 9, we were probably going to end up seeing 1, and they're going to start flexing nurses out. That means that there isn't the extra time. So the time to actually go through and maybe do some of those more ambitious things that a physician or nurse might like to. And with that extra time, have to always remember that extra time is very closely and carefully accounted for. And as soon as it starts to appear, they send people home to make sure that there isn't any waste in that system. And again, that goes back to the efficiency, trying to maximize the profits, and maximizing the profits goes back to the capped rates that you see from government payers. And it also goes back to some of the underhanded techniques that insurance carriers on the commercial side, like a UHC and Blue Cross, will do, where they'll authorize services and then not pay because they say something changed or wasn't medically necessary, or they'll set up systems that make it more difficult to get notifications to them so that they can deny on technical merits to say we weren't notified. So therefore, even though this person came in, they were in an automobile crash, they were an anonymous patient because of the trauma. Nevertheless, you didn't notify us, so we're not going to cover the stay. There's an awful lot of money healthcare providers lose that insurance companies keep in their pocket, except for, of course, the bonus that goes to the CEO that comes from games that they play in, little schemes around authorization of services. Patients don't typically see that part of it because it is an internal battle between the healthcare system and the insurance company. And so when there's a denial or whatnot for an authorization issue or a partial denial, it just gets written off. But that write-off is a loss of revenue, and that loss of revenue then means you have less margin. Less margin means you can't afford to have doctors and nurses around doing anything other than treating patients in the strictly medical model.
Now that we've delved into a few things on the administrative side and covered the physician side, what else in an overview does the administration deal with? And then I guess just in general, how does the board, I guess, overseeing everything, the administration and the physicians, where did they come into? So I'm thinking maybe there's some of the standard hiring and firing practices, anything that's outsourced versus in-house. Let's see, what are some other just general areas of the whole thing that haven't been mentioned yet?
Well, you've got, when it comes to the administrator, it's a unique business model because the patients don't ever come to see an administrator. They're not there to see somebody in a back office. They're not there to see a hospital president. They're there to see a doctor. And because of that, the face of the business and the purpose of the business is separated from the people who are supposed to sort of be making sure that it's run well. And as a result, there is bloat. There are incompetencies that come in because the standalone business operation of how we would monitor those authorizations, how we would pursue claims and contracting and make sure that we are availing ourselves of our full legal rights. Those things are not necessarily the top priority for back office staff, so much as it is, hey, is it Friday afternoon yet? And that happens because they're not running an independent company. Patients are still going to doctors. Doctors are still doing the best that they can. But behind that, it's one of those things where there's a hole in the bucket and there are a lot of missed revenue opportunities. The system I was working for, we would see multiple mistakes made by individuals responsible for securing authorizations. And I could think of one employee whose work I occasionally checked wasn't in my department, just one of the functions. So I would see some of the authorizations that she failed to do on admissions. And this one employee, just on a handful of cases I randomly audited, cost the company, cost the healthcare system at least $2 million. And that's in actual payments, not just in what would have been charges driven down by a percentage. And that's one person. So administratively, when you look at what is a board doing, how are they handling it, what's the culture and expectation and the standard for taking care of the business, taking care of the patients, because there's such a separation of whom we're coming in to see versus who's actually handling the back end process. There's a lot of people in that business that you wouldn't come to see. They wouldn't be able to run their own business, and the model that they follow wouldn't be successful. So that's something that's a concern when you look at it from the inside. Is it's bad enough if the insurance company is playing games, but you really shouldn't be making it easier. I never really observed any significant difference in the quality of care in regard to internal versus external. I certainly have heard people espouse the opinions of, like, oh, this is a contractor group, so they don't care much. But if it was internal, I don't think it makes too much of a difference, at least in my observations, because there's such a high standard required for physicians, to get through that training, to get into that field. Outside of a few with difficult personalities, where that personality might interfere with care, you don't see a drop off like you would in other areas where we're outsourcing. Say our customer service isn't going to be domestic; we're going to send it international, and we're going to give people funny names, and nobody's going to be able to understand sort of their accents. You don't really experience that. The pressures don't change in terms of if you have a vendor, say in an ER, they're paid per patient under most models. So there is some incentive to cycle through patients as quickly as possible. But the truth is, how do you know if that's impacting their care? If you had people in-house, they would also be pressured by the administrator to see as many patients as possible for the revenue. So you can kind of look at that either way and say, well, hey, they might even be less responsive to that pressure because at least they don't work for the hospital that they're actually stationed at. So there's nobody physically in their face that can be telling them, hurry up, so they can conduct their business appropriately and then go back to their boss, off-site and sort of share that they did things as they should. So I haven't seen that being a major thing. I think the real challenge for the board of directors is to continue to push an evolution into the reimbursement based upon quality of outcomes. The quality of outcomes really is dependent on the quality of care, as well as those inputs and things that we've touched on in terms of personal lifestyle choices, the diet, exercise, and making those more accessible as choices for individuals who may not know the pathway or have the opportunity. How can that be created? If we actually were looking at an environment where you were reimbursed for quality of care, say at a primary, patient came in, they had these 3 chronic conditions that can be influenced, can be ameliorated, reimbursement rates going up from the government sponsors as well as hopefully commercial carriers as those numbers begin to drop. That would be good. That's where they're heading, but it's still, pretty much still coded off and build out just fee for service. So I think that's, from the political standpoint, from the interfacing with the economic portion, continuing to put forth the idea that the more we can invest in holistic care and going beyond just a strictly medical model, the better outcomes you're going to get for the patients, and understanding that it's an area that both patients and probably physicians could use additional education of how to address things beyond, having to use medication as your intervention for pretty much everything.
Sure. And I'm hearing this more and more. And I think the writing's on the wall now, and they're starting to see the writing on the walls as far as more holistic systems. Well, thanks for doing this. And is there anything else you'd like to leave us with?
No, I don't think so. I think it's an interesting topic, and I think we're all very much concerned that I think we get lost sometimes in worrying about particulars of the insurance and what should be and should people have it or not. And there's a deeper need there just for how do we make ourselves healthy and how do we benefit our community the best that we can, and looking for a model that is based upon that, and allocating the funds where they need to be, and kind of making sure that we balance out the money that's floating around there to make sure that we're able to do that. We shouldn't, as somebody who's worked on the revenue side, it's a little frustrating to see, like if you look at the stock value of a UHC, UNH trading going up, 250, 300% over the course of 5 years. Great. And I know there's acquisitions to it, but it's not so great if you have those profits happening that are coming from premiums and are coming from non-paid bills to healthcare providers. It's not so great if it's happening in an environment where patients are only getting 7 minutes with their physician, where small rural hospitals are having to close because they can't afford to pay the bills and things of that nature. So we have to be mindful that as much as we love profit, we need to make sure that the system works for everybody, and because health is so integral to our day-to-day experiences, both for us and for others as our health impacts them. That's something that I look at and think we shouldn't politicize as much as we should just look at it and make sure that at the end of the day, the healthcare system has the funds it needs to actually pursue quality of care, because they certainly can't do that if they're not getting paid for the care that they render.
Indeed. Lots of great points. Thanks again for doing this.
All right. Thank you.